Whenever I find a difficult ECG, I always feel like whether I can refer to a friend who knows electrophysiology more than me. And I always refer to my friends. Dr. Aparna, I welcome you.
Thank you so much, Doctor. Thank you very much for a very warm welcome and your kind words of generosity towards me. So I think we chose this subject particularly because we thought that we haven't really given this speciality its due. To put things in perspective, I thought I must start that for the journey of an electrophysiologist begins, of course, like all of us with our MBBS degree, and we remember in our first prof, we read anatomy and physiology. That's where the seed of electrophysiology is actually sown. Because it is from there that we begin, and subsequent to that, few of us choose medicine, few of us choose surgery, subsequently few of us choose cardiology after medicine, and very few of us choose to become electrophysiologists. So to cater to this 1.3 billion population of our country, we have only 300 registered electrophysiologists with the Indian Heart Rhythm Society. So that's the reason we chose, because why? Often when the patient goes to a non-electrophysiologist, he may not get the care which it is due for him. So we have to understand the nuances of this speciality. As you can see here that, Nisha, do we have a pointer? Is this a pointer? Could you just help me with this? So this is simply the heart chamber with all these complex wires, and it is somehow the complexity of these wires. It is somehow the complexity of these wires which actually keep people away from electrophysiology. So coming back to anatomy and physiology, it's okay, thank you. Coming back to the anatomy and physiology, this is what I want to tell you, that we as electrophysiologists spend a lot of time understanding the muscle strands which are present within the ventricles as well as within the atria. This is just to show these markers which are there are implying to tell you the number of structures within the cardiac silhouette that we actually study and understand as to where the arrhythmia is originating from. So to keep it very simple, and I think we must have gone through this animation several times, we've all agreed upon that this is Dr. Chauhan. So this is the SA node of the heart. Subsequently, I think we have Dr. Kalra and the others sitting in the AV nodal area to take over from there. Then the electrical impulse enters the AV junction, beyond the AV junction, the bundle of His, and it then reaches the bundle branches, the right and the left bundle branches, and subsequently arborizes into Purkinje fibers. And there are zillions of these Purkinje fibers which are responsible for near simultaneous contraction of the ventricle. As an electrophysiologist, my role is largely limited to two: management of arrhythmias and management of heart failure. Let me share with you, post-COVID, there certainly has been an increase in the incidence of arrhythmias that we are noting, increase in sudden cardiac death which we have seen. Also, it is not only COVID which has caused this, it is also people are becoming more aware, wanting treatment, reaching out to their doctors, and hence presenting themselves with the problems that they have. We have never done as many ablations in the past years as we are doing now, and I'll show you what I mean by that. So whenever we talk of conduction system disease, it is either the patient is having, you're all aware, a low pulse rate, which is called bradycardia. Heart rate in adults less than 60 is bradycardia. Heart rate more than 100 is tachycardia. That can be supraventricular tachycardia, or it can be something which is very ominous and fatal. It could be ventricular tachycardia. So I'll walk you through all of these in the next 25 to 30 minutes. The most important thing is diagnostics. When a patient comes to us complaining of any symptoms, we as clinicians should not shy away from ordering tests. You must exploit the diagnostics. You must do as much as you want. Even in the medical legal fora, it is said that if you ask for diagnostics, you're not doing wrong. So we ask for an echocardiogram. You should ask for a Holter. You should ask what you're seeing here. This is an external loop recorder. This external loop recorder can be worn for 3 days, 7 days, 15 days, 30 days. It's very common now. What you're seeing on the right is an insertable loop recorder. A word about insertable loop recorder. Now this is a loop recorder from Medtronic. This insertable loop recorder, how does it help? This small little thing, which is like a pen drive, you can see, helps to monitor your rhythm for as long as 3 years. It is MRI compatible device. This little device is fed that if the heart rate goes less than 40, if the heart rate goes more than 150, it will record. That number is changeable. So that's what is called an insertable loop recorder. In the United States, this loop recorder is actually inserted in an OPD setting. And I'm showing this to you, and when I was making this presentation, I was thinking, some of you may be tempted to do it in your OPD clinic. And I thought to myself, what's wrong? Why not? Insertable loop recorder is something anybody who has a sterile cath lab or a C-arm can do an insertable loop recorder. This is how we do it. Just under the skin with a plunger, we push this little insertable loop under the skin and we just give one suture here. It stays for 3 years. It monitors your rhythm. It can also have remote monitoring. So after the help of a Holter, loop recorder, insertable loop recorder, if the patient needs a pacemaker, it could be a single chamber, it could be a dual chamber pacemaker, or it could be a leadless pacemaker called Micra from Medtronic. What is a pacemaker and how it is implanted? Very simple. I think we are all aware. We enter the subclavian vein and then we enter the superior vena cava into the right atrium, tricuspid valve, and you can see the right ventricular lead going to the right ventricle, the right atrial lead into the right atrial appendage, and these two leads are then connected to the pulse generator. The pulse generator is then placed under the skin. We make a little pocket here. These pacemakers have a battery life of anywhere between 12 to 15 years. We call these patients back to us every 6 months for a battery check. They are extremely robust devices. These devices hardly ever fail. That's the pacemaker. We're getting more smarter with time, and you can see we are giving these devices to very complex patients. They could have valves, they could be transcatheter aortic valve replacement patients. You can see here the jungle of leads because these patients survive long and they have several replacements of the leads and their devices. We are moving ahead. We have realized that the conduction system axis I just showed you goes through the AV node, the bundle of His, the right bundle, the left bundle, and to the Purkinje fibers. Now I showed you when a patient needs a pacemaker, you land up giving the lead in the right ventricular apex. Sure enough, this is not desirable. The electrical impulse is supposed to come from above and go down. Now we are pacing from the right ventricular apex, which is certainly not desirable because the electrical conduction here is taking place opposite to what should happen. You saw the electric current comes from above to downwards, but here the electrical activation is from below upwards and results in dysynchrony of the ventricle. To combat this, Medtronic has come out with a new pacing technique called the conduction system pacing. What do we do in that? As you can see here, we place the same leads, but the lead goes across the septum. We go here, we go across the septum. We don't place it in the right ventricle. We place the lead across the septum and capture the left bundle. As a result, we are able to give synchronous contraction of both the ventricles. This is what is called conduction system pacing. And of course, the third point, the most important point, is leadless pacemaker. All of us are well aware about leadless pacing today. It's like a capsule. You can see it is absolutely the size of a capsule. Remember, the Achilles heel of all pacing devices, be it pacemaker, be it defibrillator, be it CRT, the Achilles heel is the pacing lead. So if you can do something without the pacing lead, that may be very desirable. So the leadless pacemaker is a capsule which is positioned at the apex of the right ventricle. So you can ask me a question as to why is this not the adopted therapy today, even in all patients. One, because it is expensive. Second, we are unable to pace the atrium today by this leadless pacemaker. This allows us to have atrioventricular synchrony by pacing the ventricle, but this pacemaker still cannot pace the atrium. But this is to give you a perspective that we have several kinds of pacemakers, and today we have a pacemaker without a lead. It is called leadless pacemaker. So that was about bradycardia. When you have bradycardia, you give several types of pacemakers. What do we do when you have tachycardia? If your heart rate is more than 100 beats per minute, which is inappropriate for that activity. For instance, if you're sitting right now and your heart is beating over 100 beats a minute, it is abnormal. It should not happen. And when do we get tachycardias? It could be arising from above the ventricle, so it is called supraventricular. It could be arising from the ventricle. It is called ventricular tachycardia. I'll take you through these in a very easy manner. Remember, when we have tachycardias, the treatment to tachycardia is ablation. How do we do that? I just told you it has increased. We go through the groin, the femoral vein. We place a catheter. This is the catheter, the ablation catheter, which enters the inferior vena cava. From the inferior vena cava, this catheter then enters our right atrium. From the right atrium, this catheter across the interatrial septum enters the left atrium when we are trying to do ablation of the atrial fibrillation. What have we done here? We go into the left atrium, we go into the right atrium, we go into the left ventricle, whichever chamber we want to go, and we then reconstruct the model of the chamber by using three-dimensional mapping, and then we identify where is the abnormality, pinpoint it and go and ablate it. And this is what is radiofrequency ablation. We take the catheter into the chamber of interest, and here we are giving, this is cryo, and similar is radiofrequency ablation. In cryoablation, we freeze the tissue. In radiofrequency ablation, we heat the tissue. So primary focus is to kill that tissue. You can either kill it by heating or by cooling. So that's what we do. So talking about supraventricular tachycardia, this is something which all of you in your clinics would have seen some patients who come with tachycardia, which is narrow complex. Remember, whenever you see a narrow complex tachycardia, what is narrow? If the QRS is less than 120 milliseconds, there could be many reasons for narrow complex tachycardia. But you are all aware, and you have all been labeling, those of you who are senior to me would have used a term called PAT, paroxysmal atrial tachycardia. That is what it was called earlier. Now it is called paroxysmal supraventricular tachycardia. And the causes of PSVT can be many. You don't need to learn the nuances, but there can be no better opportune time than today to just understand what happens electrically inside the heart. So I'll keep it simple, but I showed you that sinus rhythm originates from the SA node, goes to the AV node. Now this AV node area is the reason of PSVT in 70% of your patients. So when somebody comes to you with PSVT, you should think it could be AVNRT. That means the problem is in the level of the AV node. The AV node has two special pathways and the impulse begins to move here very rapid. How rapid? It can go 150 to 250 beats a minute. How do you know it is PSVT? Supposing you don't have an ECG, the patient will say, I was absolutely fine and suddenly I felt as if a train is running inside me. That's called PSVT. It's a bolt out of the blue and it will terminate also suddenly. So you yourself as a clinician can know, you should ask the patient, does it come sudden? Break sudden? That is PSVT. If the patient says, no, it happens slowly, I'm walking, it will keep increasing and it will die down slowly, you know it is not PSVT. It is most likely sinus tachycardia. That's how you distinguish. History taking, again, it's like going back to your MBBS days. As clinicians, as electrophysiologists, for us the most important component of diagnostics is a good history taking. So that's very important. You're all well aware of WPW. So what happens in WPW? There is an extra pathway. So while the impulse should have gone down only through the AV node, there is also an accessory pathway which takes the electrical impulse down into the ventricles, and that is called WPW. Again in WPW, the tachycardia happens, PSVT because it goes down the normal system and it goes orthodromically into the atrium via the accessory pathway. Remember, it is very difficult on an ECG to say it is AVNRT, AVRT. You don't need to know that, but you should be aware that that's how this behaves. Sometimes there can be atrial tachycardias. You call it atrial tachycardia because the focus is in the atrium. It could be right atrium or it could be left atrium. What is an atrial flutter? An atrial flutter is there is one loop running in the right atrium. It's like running forever. It doesn't stop. If you remember from your MBBS days, it was called sawtooth pattern on ECG. Sawtooth pattern because there is never a point in time of electrical quiescence. The right atria are always working. If the right atria is always working, it gets tired. If it gets tired, it can present as cardiomyopathy. Heart can get tired. So you should know that if there is atrial flutter, we need to act. When you see a patient of PSVT, this is something I have done in the OPD just recently, and we took permission of the patient. He had PSVT, you can see rapid tachycardia. He says, I know how to terminate it. And see, the patient himself will touch his carotid sinus and terminate the tachycardia. So, you should be knowing the maneuvers. There are 3 vagal maneuvers. Vagal maneuver number 1 is Valsalva. Pinch your nose and mouth and increase your intra-abdominal pressure. Vagal maneuver number 2, ice cold water on face. Vagal maneuver number 3 is gag reflex, induced vomiting. These 3 maneuvers can terminate a PSVT for a patient in 30% of the times. So you should teach them. And then you should refer your patient who has SVT for catheter ablation. And this is how we do. We position catheters inside the heart. There are several catheters, and then we position the ablation catheter and we give the lesion at a very specific point. And post ablation, the problem is sorted. Similarly, when your patient has accessory pathway, what we call WPW, this is what happens here. Look into this. This is what happens when your patient has WPW. There is electrical impulse. It is supposed to go only through AV node, but it is going through the accessory pathway. And what is an accessory pathway? When we were in an embryological stage, as an embryo, the heart was a tube. The tube then turns around itself. It forms the atria and it forms the ventricle. When it turns around itself, between the atrium and the ventricle, there should be no muscle. There should be no muscle. But if there is some strand of muscle left behind between the atrium and the ventricle during our embryological development, it presents itself as WPW. And because it is there, it gives rise to a specific abnormal pattern on an ECG, short PR and a delta wave, and we go ahead and we ablate. Now I want to show you how do we ablate WPW. Again, you can see there are so many catheters inside the heart. Why do we put so many catheters? Because we map the chambers of the heart. We try and understand where is the arrhythmia originating from. Once we identify the site of the arrhythmia, we go and give heat energy and ablate it. And this is an ECG, as I just told you, sawtooth pattern. Look at the ECG. There is a sawtooth. That's exactly what a carpenter uses. You can see, so this is atrial flutter. I will tell you what we do in atrial flutter. This is very interesting. Look at this animation. This is not a video movie, but this is what we have made in our own lab. We place a catheter. We take several points, and this is the right atrium. I told you, in atrial flutter there is constant electrical circuit. Look at this. In this circuit, the electricity is constantly moving. There is never a point the atria are rested. This is called atrial flutter. We go here and you can see these dots, these red and pink dots. These red and pink dots signify we are ablating the atrial flutter, and once we ablate the atrial flutter, the success of ablation of atrial flutter is to the tune of 90 to 95%. I forgot to tell you the success of ablation of PSVT is approximately 98%. It is the only disease in cardiology which offers a cure. It offers a cure. In all other diseases of cardiology, we help treat the patient, but we don't have a cure. So this is an animation, this is showing you how we do atrial fibrillation ablation. Ablation of atrial fibrillation has come up in a very big way. We still have not matured. We don't have a success like PSVT, but yes, we place catheters inside the heart. You can see in this animation that look at this catheter. It is so far, it is outside the cardiac silhouette because we have entered the pulmonary veins and we are now pulling it back. It is rewarding. Atrial fibrillation ablation is rewarding in a particular subset of patients, and that subset of patients are those patients who have heart failure with atrial fibrillation. Fear ventricular tachycardias. In COVID times, we have seen the incidence of sudden cardiac death really increase. All of you have been seeing social media, news, what is happening. I will just show you what actually happens in sudden cardiac death. So this is just an ECG showing you, all of us can make out that there are ventricular ectopics, and you can see that they are frequent ventricular ectopics. What do we do? Here we enter the ventricle. We are entering now the right ventricle with the help of an ablation catheter. We do mapping inside the right ventricle. If it is a right ventricular focus, then we go and ablate that arrhythmia with radiofrequency energy. This animation is telling you what we do again. The catheter is there. The ablation catheter enters the left atrium. It enters the left ventricle. And then it goes and gives lesion at the point that we want to get, and it ablates that tissue which is responsible for the tachycardia. So again, radiofrequency ablation. The reason I'm showing you is radiofrequency ablation we do in PSVT, we do in atrial flutter, we do in atrial tachycardia, we do in atrial fibrillation, and we do in ventricular tachycardia. In patients who have poor ejection fraction, ablation of VT is not the first choice. It's an implantable defibrillator. I will just come to that. But this is to show you what we ablate. And this is again from our lab, the live case. We position the catheter. We have gone from the IVC, the right atrium, the tricuspid valve, right ventricle, right ventricular outflow tract. We are just below the pulmonic valve. This is showing you how we recreate the chamber, three-dimensional chamber, and do the ablation. I just made a mention that when your patient has evidence of poor ejection fraction, the treatment of choice is clearly an implantable cardioverter defibrillator. When you see a patient with a wide complex tachycardia, shut your eyes and call it a VT. I showed you ECGs of SVT. When you see a wide complex tachycardia, shut your eyes and say it is VT. There is more than 80% chance you will be correct. Treat it like a VT. So now coming to, why do patients have sudden death? Why do patients who have had myocardial infarction in the past have poor ejection fraction? Why do they die suddenly? Why is COVID killing patients? Why are they having sudden deaths? This is the answer, if you understand this. So this is the myocardium, okay? Myocardium meaning thereby, this is the heart muscle. The red area is the all healthy muscle. The white area is a scar. Why is it a scar? The myocardium is dead. The myocardium is dead. It is not receiving any blood supply. Hence it has become fibrous tissue. It has become a scarred tissue. Now this scar is a perfect milieu for a circuit to take place which gives rise to ventricular tachycardia. So this circuit begins to work. When this circuit begins to work, it is responsible for ventricular tachycardia, and you can see the circuit is set. Now those of our patients who have a past myocardial infarction, have LV dysfunction, EF less than 35%, they are at risk of sudden death. Even those patients who had COVID, and if the COVID virus affected the myocardium and left a scar, they are at risk, because once a scar is formed, it is a perfect milieu. So who had a scar, who didn't have a scar, nobody knows. But there have been studies done post COVID. In Europe, they took patients and saw that how many patients actually had an affecting of their heart. It was noted on a cardiac MRI that about 60 to 70% of people who had the COVID were affected, had myocarditis. Hence, we are seeing a significant proportion of patients unfortunately succumbing to this disease. And of course, the answer, if you have LV dysfunction, if you have a milieu for VT, is the implantation of a defibrillator. I have spoken to you about this in the past, but clearly you can now make out this is the ICD lead. The patient has undergone a post-bypass surgery, and this is the ICD, which is a large device. When you feel it, you can know that this is a defibrillator and not a pacemaker. How does an ICD work? So that's very intriguing. So this is an ICD, and this is a lead which is present in both the chambers of the heart. These leads keep sensing what is happening. When there is a VT, this lead tells the device. The device immediately fires either by giving a pacing or a shock and terminates the ventricular tachycardia. I have told this in the past that these shocks can be painful, they are very effective, as much as 600 to 700 joules to terminate the tachycardia. Today, we have special devices which are called subcutaneous ICDs, which are implanted just under the skin, and we do not use the patient's blood vessels, but they are for a niche subset of patients who do not have a vascular access or do not have VT but actually have ventricular fibrillation. Again, those of our patients who have an ICD can develop VTs. Then we again go in as electrophysiologists and do what is called three-dimensional mapping of their ventricles, identify the scar which I showed you, and we isolate that scar by doing EP study and radiofrequency ablation. And this is we are doing in our lab. We identify the scar. There are several ways to identify, and we ablate inside the scar. Coming to the final part is treatment of heart failure with implantable devices. I'm sure you would have had several lectures before me talking about the good medical management of heart failure with the foundational 4 drugs. However, despite what we may do, a subset of patients will continue to have progressive heart failure, especially those who have left bundle branch block, in which we go in and we give them CRT, cardiac resynchronization therapy defibrillator. We go in and we position the lead into the coronary sinus. Not much has been spoken of in coronary sinus in yesteryears, but today, for the electrophysiologists, coronary sinus is a very important anatomical structure because it allows us to allay the symptoms of heart failure by positioning the lead within the coronary sinus and the tributaries of the coronary sinus, and we pace from the surface of the left ventricle and bring synchrony back into the left ventricles. So whenever you see an ECG of your patient who has a left bundle branch block with a wide QRS, 150 milliseconds, you should immediately think that does this patient qualify for CRT? If yes, please refer. This is what a CRT does. The CRT, there is one lead in the right atrium, one lead in the right ventricle, and the third lead is going via the coronary sinus onto the surface of the left ventricle, and there is now a synchronous contraction between the right ventricular lead and the left ventricular lead. You can see the ECG. This was the ECG pre-CRT, so wide. Look at the ECG post-CRT, so narrow. So that's how a CRT works. And this is to show you again, this is the device. There are 3 leads, one lead in the right atrium, one lead in the right ventricle, and the third quadripolar lead in the left ventricle. Thus, I'd like to conclude that electrophysiology is a challenging yet extremely rewarding a specialty. It is one specialty which cures patients of their ailments and of course reduces the morbidity and mortality of the extremely sick subset of patients. Thank you very much for your patience.
So that we can face them.
लाइट लाइट
बीच में कर लेते टेबल ने बीच में अभी लाइट आ जाएगी, अभी लाइट आ जाएगी,
ठीक है।
या
Lights, camera, action. Sir, I think it was one of the very, very wonderful talk once again.
Can I come in? I think this is a statement which when I was younger I used to believe, but now I've realized this is something which is said to one and all. But anyhow, thank you very much.
Dr. Aparna, it was wonderful, mesmerizing talk. Just to know, I'm setting the ball rolling. My non-Tulsi group people will ask first question. Mine is not a question. I'm just asking as a comment. When we ablate, how do we see that it doesn't cause a scar? Because otherwise also myocarditis and so many things, ischemia, they produce a scar. When we ablate deliberately, do we do something different than what nature does?
I think it's a fantastic question. So when we ablate, sure enough, we create a scar. But when we are creating a scar, it's a circumscribed scar in a very small zone, trying to remove the symptoms of a patient which the problem is being caused of. However, it has been thought of that when we go and do atrial fibrillation ablation and we give so many ablation lesions, are we actually sometimes harming the patient? So it's not that it can be actually written off. There are several studies which do talk about this component also. But when we talk of circumscribed supraventricular arrhythmia ablation, an atrial flutter ablation, a focal VT ablation, we don't fear at all.
Ma'am, one more question is about brady and tachy. Both are not good for us. So for tachy, we have ablation and other medicines to control them. For brady, is it only the pacing, the cause, the way out? Or if we find out the physiology about brady, why the brady is happening, why does it happen? Tachy, we know it is due to some irritation, some electrical impulses coming, just like epilepsy it comes, and we have to do the remedies. Just a comment on brady. How do we do? It is only the pacing, or we do for the positive analysis and then we correct it.
So whenever a patient comes to us with symptomatic bradycardia and we tell the patient that you need a pacemaker, the first question the patient asks us, is there no medication to remedy this? So the answer is no, because you have to understand that bradycardia, always remember symptomatic bradycardia. Many of us may be right now having a resting heart rate of 50 and we may be asymptomatic. It is not important. So it has to be a symptomatic bradycardia. The treatment for a symptomatic bradycardia is only a pacemaker, akin to when you have electrical wires inside your house and they get spoiled, they get broken, you have to replace them with an electrical wire. There is no other choice. So in bradycardia, if the patient is symptomatic, the answer is a pacemaker. Just one moment more. We've seen some doctors give drugs like oxyprenaline, terifilin, or isoprenaline. Let me share with you, they can be counterproductive. How can they be counterproductive? If that very patient of yours also has coronary artery disease, you may perpetuate arrhythmias which could actually be detrimental to the patient. So there is actually no drug. If the patient is having symptomatic bradycardia, irrespective of the anatomical location, the answer is a pacemaker.
Right, ma'am. Just last comment is about carotid massage. As the patient in your slide was doing himself, he is okay. But if we are doing, we must rule out any atheroma by noting if there is any carotid bruit. Then we go for massage, one at a time. Any comment, please?
I think that's absolutely true. The reason I didn't bring that out is I said that in today's times, actually there are 3 vagal maneuvers which we teach our patients, and none of them includes carotid sinus massage. The 3 vagal maneuvers you have to teach is increasing the intra-abdominal pressure by Valsalva, talking to the patient about ice cold water on the face, and a gag reflex. We are no longer teaching our patients carotid sinus massage, and we are no longer teaching the patient of massage on the eyes because it has been detrimental in some cases. However, we as doctors should be very well aware, one, not to hold both the carotids together, and second, you rightly put it, very correct, you must try to listen for a bruit, which 9.5 to 10 out of 10 times you will not be able to audible. But yes, that's the thing that you have to listen for an audible if you carotid bruit. If a carotid bruit is there, you will not give the carotid sinus massage.
Friends, now the forum is open, and Dr. Bobby Grewal is looking at me like a university observer of the CME. Sir, any question? I will start from you.
I think, first of all, congratulations, Aparna. Thank you so much. Well, not a question. How often? You said appropriate patients don't reach electrophysiologist appropriately. What, according to you, 1, 2, 3, would be listing the reasons for not a physician like me not utilizing your services?
Pardon me if I say that.
Please,
First
open.
answer would be ignorance. Yeah, because you see a patient walk into your clinic and you think he's all right, he's okay, I don't need to worry about him. I'll give you a little instance today. I had a 62-year-old physician who's just a physician practicing in Gurgaon, and sir came with his wife. They travelled all the way from Gurgaon to Janakpur to meet me in my evening clinic because they had been prescribed atrial fibrillation ablation by one of the electrophysiologists, and other doctors had also seen him. But let me confess that nobody had even asked for a Holter. He just had one ECG of atrial fibrillation and he says, I don't have any problems. Why should I go in for an ablation? So we have to understand that first we should be understanding the disease processes. You must refer the patient to the doctor whom you think the specialty is involved. So the first thing is ignorance, and second thing is this perception that my patient is all right. I'll give you again an example for this. We have many of our patients who are roaming around with ejection fractions of 30%, right? You think he's all right. He's walking to my clinic, I'm giving him good medications, he doesn't have any problems. I should not worry about him. And you forget about him. But he's dead. Because you never thought that he would have died of a ventricular tachycardia. So there are certain take-home messages that when a patient is symptomatic, please refer to the right specialty. When a patient has LV dysfunction, consider the patient is at risk of sudden cardiac death. If a patient has some symptoms which you are trying to treat but are unable to treat, for example palpitations. We have so many patients today roaming around with ventricular ectopics. They don't know how to treat, and the physician keeps giving him Cordron to eat. Cordron is not a drug to be eaten in ventricular ectopics. It will kill his thyroid, it will kill his liver, it will cause corneal microdeposits. So you should want to understand that there are certain times when you have to use a specialist for a given disease process.
I think I would stick to the ignorance part. When you say symptomatic, can you list what are the major symptomatic presentations that one would suspect?
Yeah.
Thank you.
First, the most dramatic symptom. Any patient of yours comes to you with syncope. We often see syncope also, he has a syncope and he's not referred to an electrophysiologist. A syncope is something which needs thorough investigation. And let me tell you, if somebody has no structural heart disease, we will do nothing for that syncope. But we must rule out the cause of syncope. Second, lightheadedness, dizziness, pre-syncope, palpitations, dyspnea, all these. And your patient who has LV dysfunction must at least once be seen by an electrophysiologist for his risk stratification profile, that does he need a defibrillator.
Ma'am, I want to ask.
I just want to comment here. जिनको हम ये कहते हैं ना, इनको बड़ी एंजाइटी बड़ी रहती है, उनका भी एक बार इलेक्ट्रोफिजियोलॉजी करवा लें तो अच्छा है, कम से कम ईसीजी तो करवा लें.
Absolutely, I think ECG is a tool which is available, is omnipresent. So today ECG is something which must be done. ECG has gives us a lot of ideas.
Ma'am, I worked in a hospital in Saudi Arabia in 1992, and I had one patient admitted under my care who was an asthmatic, known asthmatic, and inhalers was not very famous in Saudi Arabia at that time, and people were very hesitant to take the inhalers. कि आदत पड़ जाएगा. This lady was pregnant. and she was about 32 years of age. So as I had my training done in Southern Hospital, I put this lady on a aminophylline drip, and her breathlessness subsided considerably. I can say to the tune of 90, maybe more than 90%. But the sister called me in the night at about 2 a.m. and she told me that Doctor साहब इसको बहुत severe palpitation हो रही है, आप जरा एक बार आके देख लो. So you can understand, ma'am, the situation of a internist in Saudi Arabia. I went immediately and I said, kindly get me an ECG done. So the ECG showed that she had supraventricular tachycardia, and I immediately suspected that it is probably aminophylline induced. So I stopped her aminophylline, and I told the sister that you continue with the rest of the medications, but do not give her aminophylline. So she asked me, sir, ये कह रही है कि अगर ये वाली ड्रिप बंद हो गई, इनको पहले भी मिली मिनिस्ट्री ऑफ हेल्थ के हॉस्पिटल में, ये ड्रिप बंद होते ही इनको जो है दोबारा से breathlessness शुरू हो जाती है. Nebulizers was not in the vogue at that time. Inhalers were rarely used, so I advised her teriflunin retard tablet. She seemed to settle down with that, but the day I was supposed to be discharging her, she again had palpitations and the same kind of tachycardia with a heart rate of about 170/8. What would I have done better, ma'am?
Yeah, so I don't know if she had a PSVT or not, but at that point in time, you could have concomitantly now you can't give this lady a beta blocker.
Yes, ma'am.
This contract.
That's my problem. Dr. Mangla is here. He is going to put me down here below the table if I advise a beta blocker.
The only drug of choice you could have considered was diltiazem.
Pardon, ma'am?
Diltiazem.
Diltiazem.
Yeah, a small dose of diltiazem because she's a pregnant lady. So a lot of issues come there too. Working in Saudi Arabia would not have been easy anyway. So, but yes, these are arrhythmogenic drugs. That's why I said that trying to treat bradycardia or any such situations with these drugs can put you into a troubled spot.
So I will tell you, and for the benefit of all my friends here, what I did. I put this lady, ma'am, apart from the other drugs for bronchial asthma, I put her on a dose of calatin. And her tachycardia settled down.
So calcium channel blockers, absolutely. Calcium channel blockers are the answer.
Absolutely fine, ma'am. So we have lot of cases in our clinical practice who are asthmatics, but the moment we are not using aminophylline anymore, and I would like to have a comment from Dr. Mangla, sir.
I will still say that even Daripalin retard shouldn't have been given. She was pregnant, otherwise steroids was the better choice, and it could have settled down. Daripalin really causes very severe tachycardia, and patients can certainly die of it. I don't know, when I was a resident, our seniors used to tell us, come, I'll show you magic. This lady is wheezing, just see, the wheeze has disappeared. So now we realize that what we were doing.
Thank you, sir. Thank you for your feedback. I'm sorry. I think Dr. Kodar had a question.
Regarding carotid sinus massage, I think both carotids should never be palpated at the same time. This is basic lesson. What are the symptoms? What are the symptoms of bradycardia? You said when bradycardia is symptomatic, then only we should worry. So, what are the general symptoms of bradycardia?
The first and the most dramatic, which will not pass by you, is syncope. So if a patient has syncope, it will not pass by you. But the problem is, often they will have tiredness, they will have fatigue, they will have pre-syncope, they will have dizziness, lightheadedness, pounding in the heart. And because these symptoms often can be thought of, as somebody just mentioned, anxiety, or they just passed off, it is a well-known fact that often sick sinus syndrome goes by untreated. So another symptom of sick sinus is chronotropic incompetence. Means he's walking uphill, but his heart rate does not increase. So they will complain of tiredness and fatigue. They are unable to perform activities of daily living. So anybody coming with these symptoms warrants that you do an ECG at least and see what's next.
Regarding, I think Dr. Grewal's comment that why we are not sending enough patient to electrophysiologist, still we are sending most of our patients to cardiologists in general. So we have not recognized electrophysiology as special or subspecialty.
Yeah, so let me give you, I think you've touched a very sensitive subject to an electrophysiologist's heart. So when a patient comes with a PSVT to a tertiary care center and obviously comes to a interventional cardiologist, so the interventional cardiologist sees it, the emergency room anyway treats it, the next morning he schedules him for an angiogram. Angiogram is done and finds a lesion in the RCA, distal RCA lesion of 80%, goes and puts the stent and tells the patient, you are fine, go home. He comes back 1 month later again with PSVT and he says, this is what I came for, but you have not treated me, you put a stent instead. So this is actually a reality and it happens not once. That's why I'm saying, when should you think of an electrophysiologist? Because interventional cardiologists in good faith do their bit. But the patient presented with PSVT, treat the SVT, that's why he came to the hospital. We are very well aware an RCA distal 80% does not warrant a treatment, but a PSVT warranted a treatment.
And last, you said ILR can be implanted in any OT with CR facility. I think this should be taken more seriously because are you serious that most of the OT they can start implanting ILR?
Okay, so the thing is that these organizations, the industries also do not let go and do not make it such that these implants can happen everywhere. But yes, anesthetists can easily implant these devices because it needs a C-arm and just a very simple understanding of how to do it. Keeping things in perspective, working in a tertiary care center like Fortis Escorts, we also don't implant ILRs to many. Reason? Much of the service is done by an external loop recorder. But you should be aware that there will always be some patient where you are unable to capture the arrhythmia even with a 15-day holder. That's when you consider an insertable loop recorder. While there is no such criteria that an insertable loop recorder should only be implanted by a cardiologist, it is simple tool. It can be implanted by an anesthesiologist.
But only a cardiologist can say the right indication.
Absolutely.
That's why it should not be done by non.
That's what I'm saying. That's why it is not, because then it may sometimes pass on not the best hands.
Yes.
So ma'am, artificial intelligence is entering into almost all area of diagnostics. So in case of ECG machines, they give their own diagnosis of arrhythmias and other MI and other things. How accurate are that and what is the future of that? Machines giving the diagnosis.
Yeah, so I think that's something which is very good and futuristic, and I think it may not be very far away. So we are soon going to have AI available on picking up patients who may be at risk of atrial fibrillation, meaning they've never had atrial fibrillation, but the ECG analysis can tell us, because it has been fed, that if the P-wave morphology is such, it will tell us the patient is at a risk of atrial fibrillation and you need to look into it. So the machines do a fairly good job, but AI is there in a big way, and we as cardiologists are much looking up on it.
Is there any particular machine which is more, which better than?
I may not be aware to answer that.
Dr. Manish,
Yeah.
you are the
Yeah.
question.
Dr. Aparna, it might sound silly, but it was really nice listening to you. The thing is that suppose you have a patient as saying symptomatic bradycardia or lightheadedness, young people, and they complain of it off and on, off and on. And do you have a time frame in which you feel you should do a Holter or a loop recording? You know, many times a patient comes that I had this last month and recurrent, especially lightheadedness is a very, very ambiguous term, but people do complain of it often, and dizziness. So how would you approach it? Are there provocative tests which you would like to do?
So let me stand corrected. When I said symptomatic bradycardia, I missed one term, one word there. Symptomatic documented tachycardia. Bradycardia. Symptomatic documented bradycardia. What does that mean? Lightheadedness. Many of us will have it at some point in time. My threshold of putting a Holter will be, I will have no threshold. The patient walks in, he says, I have lightheadedness. I say, go get a Holter done. He comes back and he says, I was having lightheadedness during the Holter, but the Holter shows no evidence of bradycardia. So I know that it is unrelated. At the same time, if I don't do a Holter and he complains of lightheadedness, then I will be certainly missing out the disease process. So basically when a patient comes to me and complains of symptoms, post-COVID my threshold of doing Holter has really increased. I said just go get a Holter done, and we are actually picking up a plethora of arrhythmias with that. The biggest benefit of it is we pick up atrial fibrillation, we are able to treat atrial fibrillation by calculating the Jaswal's and Hasbred before the patient has a stroke. So lightheadedness cannot pass by. Somebody complains that in the young, it's even more important, because if I implant a device which he doesn't need, now it implicates his entire lifetime. He's going to need replacements, he'll get infected, his leads will break. So documented symptomatic bradycardia is extremely important.
And the success rate is not so good as you have told. How much is the success and why it fails in many cases?
So that's exactly what I said. The success of atrial fibrillation ablation is to the tune of 60 to 70% only. The success of ablation of PSVT is 98%. The success of flutter ablation is about 90%. Why does atrial fibrillation ablation not have that success rate? Because when you ablate the atrial fibrillation, first you have to enter the left atrium. When you enter the left atrium, we have to be extremely cautious. Remember, the left atrium blood enters the left ventricle. From the left ventricle, the blood enters the aorta. From the aorta arise the coronary blood vessels. The aorta carries the blood to the brain. Now when you are rolling your catheter in the left atrium, any point in time there can be the formation of clots, and those clots can embolize your coronary arteries, they can embolize. So what is the fear of the doctor who is doing the ablation? He wants to spend less time in the left atrium so that everything goes off well. Unfortunately, you have to spend a lot of time for a good atrial fibrillation ablation in the left atrium. There are 4 pulmonary veins. You have to go and ablate each point by point. That's called pulmonary vein isolation. Even if you do cryoablation, the successes are not so many. Second, it is not only that atrial fibrillation is a problem of the pulmonary veins. There are non-pulmonary vein foci also which could have caused atrial fibrillation. So AF is a very complex disease process. We never recommend AF ablation as a first line therapy. Even in the guidelines, it is recommended only to those patients who are extremely symptomatic with atrial fibrillation or have AF with heart failure. Otherwise, first step should be stroke prevention in atrial fibrillation by calculating the Jaswal's and the Hasbred score, followed by containment of the palpitations. Despite good medical management, if he continues to remain symptomatic, then you should refer the patient for AF ablation.
They say that pulmonary, artery has a very high rate of success in atrial fibrillation. Pulmonary area, vein, and that area has, I have read somewhere, I don't know.
Yeah, so that's why I'm saying that the foci of the atrial fibrillation are pulmonary vein. You have to spend a lot of time to isolate them. There will be non-pulmonary vein foci. You have to spend time there. It lot depends upon the expertise of an individual and a given center, how well they want to do it.
Ma'am, we just had a terrible pandemic for the last two plus years, and we have a lot of cases coming to our clinics who have persistent sinus tachycardia. They have lost some of their near and dear ones in the unfortunate Delta wave. Hardly any family which was unaffected in Delhi and NCR. It was a terrible time. We do their ECG and we find persistent tachycardia, ma'am. Even heart rates 120, 130. And we keep labeling them anxiety neurosis, hypochondriasis, etc., etc. What should be my approach to a patient who has been having consistent tachycardia for the last 2 years, ever since he or she suffered from COVID?
The first thing is that I would not label anxiety. I think all of us have actually gone through a very difficult time, and those people who've lost their loved ones are sure enough to be anxious than the rest of us. The second thing is, as I just mentioned, that 70% of people who were affected with the coronavirus have proven myocarditis on a cardiac MRI. So when we talk of myocarditis, the first thing that happens with myocarditis is the patient develops sinus tachycardia, can even develop other arrhythmias. We have also understood that there are something called long COVID sequelae. So this is something which is, none of us knew about COVID and we are learning it by the day. So there are long COVID sequelae wherein inappropriate sinus tachycardia is actually one of them that we have read and learned. The treatment in these cases will be and should be ivabradine. Ivabradine is a good drug. However, if you want to connect that with reduction of the anxiety symptoms, it's a good idea to add propranolol. So a combination of propranolol and ivabradine should be good, provided you have done an echocardiogram, you have done a Holter, and you're sure that the patient has no structural heart disease, and give these drugs, and that's what you should do.
Normally, what will be the maximum or the optimum dose of ivabradine that you build up to?
So the recommended dosage of ivabradine is 7.5 mg twice daily. It should not be used in two situations, one in the very young and second in the very elderly. The only side effect of ivabradine is that it causes phosphenes, and these phosphenes, it causes discoloration of your vision, because ivabradine acts on a specific current called the funny current, IF channels, which are present in the sinus node and on your retina. So the phosphenes or the yellow current, yellow discoloration, the children cannot tell you and the very elderly may not tell you, and they may be developing the toxicity of the drug. So it is contraindicated. Outside of that, the recommended dose is 7.5 mg twice daily. The drug being so safe as it is, we have used even up to 10 mg twice daily.
Okay. I think Dr. Kalra mentioned Tulsi and non-Tulsi group. I think now it is time to go to the Tulsi group.
Where is the group, sir?
Actually, here starts the journal club, the new and what is next to come, next generation or then next, sir.
So, let me say, Dr. Aparna, that was a magical talk, as usual. Simple, yet very concise. And I am very excited, see, as a clinician, to know about the latest in ablations. Especially after those brainstorming sessions at the recently concluded Rhythm Society conference, which they donated a lot of time on ablations. So 750 faculty members there, I think you were there. So cryo, radio frequency, laser or pulse field ablations. Which do you choose? I believe the laser and the pulse field ablations are good and the latest, but if you ablate well, all are fine. What do you say, ma'am?
And so I must tell you that we all work in institutes and not all of us are fortunate to have all the therapies to be offered to a given patient. You need consoles, you need special infrastructure, you need special hardware. For instance, we in our center are using what we call 3-dimensional mapping with a CARTO system, and we do radio frequency ablation. That in itself costs approximately 2 to 4 CR. Trying to invest in a cryo is another 2 to 4 CR. So sure enough, cryo seems to be the way forward because it is shorter, it is simpler. It is not that it is better than radio frequency ablation. Under no circumstance, it is just proven to be shorter. Its successes are not anyhow greater. So all this depends upon a given center and the training of a given individual. There will be people, if you go to France, Michel Hassegal is the father of atrial fibrillation. They just do 2-dimensional mapping. They don't even use 3-dimensional. They have the highest successes. So it depends on what you're trained at. And today for atrial fibrillation, still we don't have that, okay, this is the answer. Just do cryo and come out. We still don't have that.
Right. So, talking about little about the rhythm or rate control in atrial fibrillation, there have been mixed results. Historically, rate control, but the data, which is probably better outcomes have been seen with rhythm control as compared with the rate control. So, recent article in NAGM, in Circulation, and Mayo Clinic Proceedings as well, they all favored rhythm control as compared to the rate control. Your words, ma'am.
So, if we look back, landmark trials told us it is intuitive to believe that rhythm control should be better. It is intuitive to believe. So they did those trials in the years about 2000s to see if rhythm control was better, but they failed. Why did they fail? The rhythm control trials failed, and they said rate control is better. We just mentioned that. Why is it?
No.
That we just
Just the opposite.
No, that's exactly what I'm saying. That when we did trials in the year 2000s,
Yeah, previous trial.
why did they fail?
Yeah.
Even they should have shown rhythm control is better. They simply failed
Yes.
because the benefit of a rhythm control was offset by the toxicity of the drugs.
Right.
What drugs? Amiodarone.
Moderator.
So what do? We did not have radiofrequency ablation then. Today we have a therapy to offer to our patients where they can be free of a drug as toxic as amiodarone.
Absolutely.
So it is intuitive to believe that should do better. So rhythm control has to be better.
Absolutely.
Also it has been noted that those of us who tell our patients that no, it's okay, live in AF. Many of us still do that. Even we do that as electrophysiologists. The patient says, I'm fine in AF, I don't have any problem. The answer to that is, he doesn't know how it is to be in sinus rhythm. When he comes back into sinus rhythm, he will know how much better he is. So it is but obvious that sinus rhythm is better. And we have a gastroenterologist amongst us. He'll tell us how toxic amiodarone is. I mean, both of us will tell our regular physicians, please don't use amiodarone. It's a very toxic drug.
Our pulmonologist is also here. How toxic it is for, to the lungs.
Yes,
Because ILD, we unfortunately lost one of our cardiologist friend due to amiodarone toxicity. Dr. Isam, you would know. Okay, ma'am. So, why is AFib more common in women?
Well, atrial fibrillation, I won't say is more common in
I'll
women,
tell you,
but it
ma'am.
is more toxic in women. However,
No.
they have higher circulating catecholamine levels, and that's an established fact
Okay.
that women have higher heart rates.
So, probably women have more AFib because they live longer. And as we know, the longer you live, the chances of having AFib is more. So, okay, ma'am, just recently published article in JAC, also in the Journal of Radiology, talked about the CMR which you mentioned. So, a powerful tool in predicting sudden cardiac death, arrhythmias in presence of myocardial fibrosis, and it may also improve patient selection in CIEDs. So, as we know, these devices are unquestionably effective in preventing sudden cardiac death. So, the role of CMR in such like situation, not only that, even in COVID-induced myocarditis, if you have an LGE, which is a late gadolinium enhancement, so these are the early markers to pick in CMR. Ma'am, your word on that?
Yeah, I think I completely agree. You've already said it all.
Right. So, did you see some long QT syndromes in COVID-19, especially when they were, on SCQS and macrolides?
So let me tell you that when hydroxychloroquine came in a very big way, we actually did a study with All India Institute of Medical Sciences to understand, is HCQS actually going to move? How has it helped? It is very well proven that hydroxychloroquine actually kills people. And it not only causes prolonged QT, it can even cause bradycardias.
Yes.
So we moved away from there.
And especially when you combine it with drugs like macrolides,
Absolutely.
and surprisingly, the IL-6 inhibitor, tocilizumab, reduced the QT interval. Okay, so ma'am, my last observation, not my observation, the JAC, Clinical Electrophysiology, again in the Heart Rhythm Society said, women cardiologists like you, see 48% of the women doctors joined medicine, 24% joined cardiology, and just 6% joined electrophysiology. So they said they were probably the three things which have prevented women from becoming electrophysiologists were: one, the long training; two, lot of probably radiation exposure; and third was probably it's an old boys club. Yeah, ma'am, your impressions, your words of wisdom on them.
All three.
Yeah, no, the first two yes, not old boys club.
Not old boys club?
I'm not a feminist and I don't believe that if someone has passion within themselves, any one of us can be anywhere. So no boys can stop a woman from going wherever she may want to.
Wonderful. Thank you, ma'am.
I think, friends, we had a wonderful session on electrophysiology, and I'm sure you would have understood the basic message of the talk by Dr. Aparna Jaswal ma'am of when to refer your cases to an electrophysiologist. Okay. I understood only two things. One was sinus bradycardia is when the heart rate is less than 60, and sinus tachycardia is when the heart rate is more than 100. You must refer a case of yours if the patient has a persistent bradycardia, unexplained, and if your patient has persistent tachycardia, not 100 doesn't make a difference, 120 especially, refer those cases to Dr. Aparna and let her investigate what is the underlying reason.
Rhythm abnormalities as well.
Rhythm abnormalities as well.
That is the.
And therefore, I leave it to our wonderful chairperson, Dr. M L Kalra sir, to summarize this wonderful CME for all of you. I just saw some of you were sleeping, but just wake up now. Just wake up now and take the carry-on message.
Sir, wake up call for all of you. पहले तो मैं डॉक्टर अपर्णा की तरफ से ये कहना चाहता हूँ कि why should boys have all the fun? आपने कहा कि old boys club वाला ऐसा कुछ नहीं है. I'm also rejoining to Dr. Grewal's question and remark that why we are not referring patients to the electrophysiologist. Probably, Dr. Aparna, with electrophysiologist, our PR interval is long. We are having very less CMEs with the electrophysiologist. You are the one, and another one was Dr. Punita, I think once in a year or so. So we are happening with the cardiologist so frequently, once a month or say once in 6 weeks. So they are probably, we are not having that much of interaction, but we are now getting aware and eyes are opening. We are definitely better than the last meeting. Attached to you. We are really closer to you now. Not the PR interval has reduced as per WPW syndrome. इतना कम तो नहीं हुआ, पर काफी कम तो हो गया है. Before I wind up, any complex ECG demands one comment from our electrophysiologist at least, and any case which we feel needs electrophysiologist help, we should be very easy, and I think everybody will have her number today to have a talk, and any complex ECG you are feeling a problem, kindly refer to her and she will answer. This is my request to her also, and just my one comment I'm making, when we are facing at the right apex, we are going beyond that. Why not we are facing at the AV node? Is there any hitch there?
Yeah, so just showed you that we're now moving into the conduction system pacing, and that's what we've begun to do now.
And the slow and the fast pathways in the AV node, are they present in everyone or only in those who are having tachycardia?
So they're present in 25% of the population, but they express themselves in a minority.
Thank you so much. I'm glad I moderated the session.